Hello, everyone. My name is Hesham Gaafar from the University of Chicago. I am a physician, public health, and precision health specialist. Thank you very much for tuning in and for the opportunity to speak to all of you in the Smart African Network. A particular thank you to Professor Ogobole for the invitation. It is very much appreciated. Today, I will speak about precision health and how it relates to imaging, particularly now in the age of AI. The objectives of today's talk will be to discuss what exactly is precision healthcare, what does it mean, how is it being applied particularly in imaging and around the use of artificial intelligence, and then how can we use it effectively. To start off with, what is precision healthcare? Well, the reality is this is a relatively new field, and as such, it is still being defined and refined. And you will find that there are multiple definitions for what is precision healthcare. And depending on your interpretation or where your sources are, you'll find that they can be quite different. Here are three examples of institutions here in the United States, and you will see that their definitions can be quite different. Stanford Medicine focuses on the prediction, prevention, and curing disease precisely, i.e. looking at their application. The CDC, discriminating between precision medicine and precision health, says that precision health is mainly focused on where it is located, looking at the broader approach that it occurs beyond the clinic while looking at multiple factors. UCLA, however, takes a different approach, looking at the idea that precision health is defined by the variations of inputs that go into developing the insights. So can be quite different, and they are all technically correct, as this is, as I said, a new field and still getting defined. Based on the definitions and examples we just discussed, it might seem a bit odd because they seem to overlap with other terms that you might come across, such as personalized medicine, precision medicine, and targeted care. And so there are some differences. So personalized medicine focuses just on the individual, and that means we are not focusing on the population level, and we cannot develop policy or guidelines based on a personalized medicine or care. And this is usually care that is developed and applied at a clinical level. Precision medicine is similar in that it is also done at the clinical setting. However, it takes more inputs into consideration and can look at the group of individuals, while targeted care focuses on a specific target, genetic or otherwise, that we try and focus on to deliver either a specific treatment or care. The definition I prefer most for precision health, and not only because it's from the University of Chicago where I'm based, but because I think it is the most accurate, most encompassing, and most useful, is it is the interpretation of the genetics, behavior, and environment of an individual or group of individuals to be used to develop prediction, prevention, diagnosis, treatment, and management of disease in clinical and out of clinical settings. And I think this is the best approach to defining precision health and will be the way I use it for the rest of this presentation. Now that we have defined precision health, it is important to also know what are the key principles of precision health and the outcomes that we expect from any precision health approach. Precision health needs a predictive and preventative capacity to reduce the number of people having a disease or a condition, as well as predicting those before they have it. It needs to be personalized, so developed for either individuals or a group of individuals or a set of characteristics, and it needs to be accurate. It is not a blunt tool. It needs to be patient-centered, focusing on the patient or person and their perspective of disease and experience. The amount of information that is needed to develop precision health insights is very large and requires the participation of multiple stakeholders from both the patient and provider perspective, and therefore it is a participatory process that is co-produced together, and ownership and regulation of it must come from all sides. The results of precision health must be preeminent. They must advance and improve on current practices. As there is a lot of resources going into precision health, they must be worth the investment. Precision health is a very promising field with great potential, and it has potential across multiple areas. In prevention, it is likely to help identify those who are at most risk of developing a certain condition or certain complication, and therefore we can act earlier based on those predictions, preventing those people from ever developing the disease or condition, improving outcomes and quality of life. Similarly, we are able to better identify those who have developed the condition at an earlier stage before complications have developed or before the disease reaches its late stages, which have a higher disease burden and further impact quality of life. Also, with precision health, we may be able to improve our research efficiency as the questions we are asking become refined and we know where to look based on the predictions of which results or based on pattern recognition within precision healthcare. Precision healthcare can also improve decision making within the research space, as we said, identifying which research questions to ask and which areas to focus on, but also within a clinical setting by identifying which people respond to best, whether based on certain characteristics or features that they may have. Precision healthcare also has a great potential in terms of education and training, as we train people to look at multiple factors and a holistic approach to treat the patient rather than treating the condition, and also to use new technologies such as AI to develop resources that people can use to improve their capacities. And similar to the research, pharmaceutical discovery can be improved as we focus on certain conditions based on what their characteristics are, how people respond to them, and the people that tend to have these conditions, what their environment and lifestyles may be. And of course, as we improve precision healthcare and all the other factors and improve the quality of life for individuals, we are hoping that this is targeted towards those with the highest disease burden, therefore improving equity and as well as general population health and well-being. The image and perception is that precision health requires high resource settings to be utilized. And while it might be true that in most cases at the moment, precision health approaches are being utilized in high resource settings, it is not a necessity. Precision health can be applied in low resource settings effectively, and it is arguable that in low resource settings, we can have the greatest benefit from a precision health approach. In low resource settings, there is usually limited infrastructure availability. So in the example of imaging, we might find that in many low resource areas, there are very few MRIs. The lack of availability of MRIs and trained staff to use them means that we have a low amount of MRIs available to diagnose or to utilize for treatment of patients. And therefore, every MRI that is used that comes out normal or negative or so on might be an unnecessary strain or use of the infrastructure that is available. Using a precision health approach, we can then refine who we request for more advanced imaging or the use of an infrastructure, allowing more effective allocation of the infrastructure usage without straining it too much. There is also tends to be a higher burden of disease in low resource settings, whether biological, that those who are in low resource settings might be diagnosed later at stages, and therefore the burden of disease in itself is higher, or that there are more environmental or lifestyle risks associated with it, increasing the aggressiveness of the biological condition. There might be also higher burden economically from the disease, as the cost of treatment or the cost of disease itself might be much greater proportional to the economic output of the community or the individual. And the social implications, whether due to loss of work, lack of safety nets, or stigma, might be higher than in other areas. The role of precision health here is that we can then identify those who are at highest risk of developing the disease and at highest risk of facing these challenges. As we said, this covers both in clinic and out of clinic to target them, to ensure that our resources are directed at those most in need, reducing wastage, and also having the biggest impact, improving efficiency and prioritization, improving outcomes and results in the low resource settings where there isn't much resources to be wasted by definition. In low resource settings, as with the example of the MRI infrastructure, it means that also the resources that are being developed, such as the images, are limited by the number of MRIs, the number of hours, and the number of patients with access to those MRIs. And what that ends up meaning is that there are fewer resources that are of local origin to be used in research to identify new diseases or new disease patterns or conditions or any other medical relationship, and also fewer resources for students or trainees to practice on and learn from that are relevant to their context. With precision health and AI together, we can generate more images that are based on local individuals to be able to allow people to train better and identify the conditions or the structures and within the context that they will be practicing on, rather than imported from another area where there is greater resources, but might not be as relevant. In lower resource settings, we also tend to find that the capacities available tend to be very strained and running at below optimum capacity levels. So, for example, physicians and healthcare providers could be very stressed, experiencing burnout, as they are seeing a lot more cases than they probably should be seeing. And I am guessing most of you don't need to be informed of that and probably experience it in day-to-day life. Therefore, with the precision health approach, we then reduce the number of uh, cases that need to be seen by individuals that are already strained because we are targeting those who only need it, reducing the wastage. But also, the approach means that by reducing the strain, that when people are working, they are operating at optimal capacity because they're not seeing as many cases or seeing as fewer irrelevant cases. These together provide not only that an argument for the need of precision health in a low resource setting, but they absolutely show that there is a demand for it, and it is an imperative that we develop precision health capacities in low resource settings, and that AI can be used to help develop that, and we will be discussing that a bit later on. This brings us into the interaction between artificial intelligence within precision health. So we've discussed a lot about precision health, what it is, and how it is not a field or a tool, but rather a unique approach to the patient and population based on their multiple characteristics and the outcomes we want from them within the different settings, clinical and outside of clinical. Artificial intelligence, however, is a collection of tools. So tools may be machine learning, neural networks, deep learning, and so on, that can be applied in a precision health approach to develop the insights we were discussing. And radiology and imaging, as I assume most of you know, is at the forefront of this field because of its unique and defining characteristics. The nature of radiology, as we discussed, puts it very much at the frontier of artificial intelligence and precision healthcare. And this is because of features ingrained within the nature of radiology. The start of it is very conducive to big data analysis, which is necessary to train models and develop insights for artificial intelligence and for precision health. So the 5 V's necessary for big data are velocity, so that there's a lot of information being produced. And as you may all know, there's a lot of information being produced by a lot of the images that are happening day to day across the world and within your hospitals and communities. So they happen very frequently, creating a lot of data. The volume of data is also very important. So as we said, if it's occurring very rapidly and on a regular basis, that means a lot of volume of data is being developed. So we have a lot of information to analyze and data points to look at. Of course, I do not need to talk about the value of imaging to a group of radiologists and practitioners. As we all know, radiology is indispensable in helping people diagnose and can provide a lot of insights about the condition and individual. So it is a very valuable insight. There's also a great deal of variety. There are multiple forms of imaging of different parts of the body, and imaging of different individuals. So all of this provides a great deal of variety that can be then used to interpret different data points, make connections and understandings. And of course, the veracity or the accuracy of the data is very important. And considering there are most radiologists interpreting this, as I'm sure you're all very aware of, have gone through rigorous training and standardized examinations. So when we have final interpretations, they can tend to be very accurate and comparable. The format of most radiological interactions is also very important. These are usually electronic images or electronic reports, and that makes them very easy to extract and develop models that can interpret them and find insights. And I know in a lot of situations, this might not actually be the case that they are in electronic format, but in even those situations, they are probably more a higher proportion of the radiological data is in electronic format compared to other healthcare data within that context. So they are usually at the forefront of electronization and digitalization in healthcare, making them at the frontier again. Finally, as we discussed, as a healthcare field, radiology is very standardized and does not have a lot of subjective interpretation, as maybe something like psychiatry might have, and therefore it is easy to compare and test across institutions, practitioners, and so on, and identify disease conditions based on standards, definitions, and for diagnosis. So all of these features make radiology very useful for AI and precision health and putting it at the frontier and where we're expecting to see a lot of the explorations and breakthroughs within the next few years and in the long-term future. This is a very crude interpretation of the radiology flow, just to give us an idea of where we'll be focusing and to help us organize ourselves. So the radiology flow starts when the patient comes in, and depending on the access they have to the center, whether it's geographical access or coverage access, and then they have their image generated by actually receiving the scan, whether it's MRI, CT, ultrasound, and then there's interpretation, or the first stage of interpretation, which is detection. So we find certain patterns, or we find an anomaly or lack of anomaly. We then look at patterns, so if there are multiple anomalies or multiple features we've detected, how do they come together? And then the final stage of interpretation is the cognition, thinking about how the items we've detected and the pattern we find align with other clinical features we may be aware of or with other findings within the imaging to develop a recommendation, diagnosis that we then share. This is then shared with other partners in the communication form based on a report or a finding summary, or however is the preferred mode of communication with other clinical providers. Here we'll be focusing for the rest of the talk on the center portion, so image generation and interpretation, the three stages: detection, pattern recognition, and cognition. So let us begin with image generation. So as we said, the usual way of generating an image is to actually scan a patient, whether MRI, CT, or ultrasound, as we discussed, and then you have an image of the patient and interpret that or use it for research and training. The other option to use in AI is to generate a new image. And these generated images, we would like to call them fake, are not based on real patients or real Here you're able to see something in the figure of something called a generative adversarial network that can be used to develop images. It consists of two neural networks. It's a machine learning model. The generator in green and the discriminator in blue. The generator would create synthetic data from noise, as we see here in the seed, creating an image that we see the generated image. That we want to try and get as close as possible to the real image to make it indistinguishable. The discriminator then tries to distinguish between real and fake data. Then training from both ends, they are competing against each other. The generator continually improves based on the discriminator finding out whether it's true quality, then discriminator loses, and information goes back to the discriminator to improve how it detects fake images. If it's true quality is seen to be fake, then the generator loses, it goes back, and this informs the generator to create better images. This approach, as we discussed earlier, can help us generate more images from local data that can look at combined multimorbidities that are found within certain contexts or rare diseases, as well as creating more options for students and trainees to train on and learn from. This way we have a broader database to train other machine learning and our students to improve their knowledge and capacities. It is also important to note the quality and usability and feasibility of the data that is being generated, especially in these models, as some information might be produced to be inaccurate. So this is an example for training self-driving cars to identify when to stop. And as you can see, the idea is to help them identify the stop sign, and we can see transformer-generated images of different stop signs so that the image can detect it, and the car can stop when it comes across the sign, even if it comes from a more obscure angle or from somewhere where it does not have a direct field of view. There is, however, an issue with some of the signs available, and I'll give you a moment to take a look, and maybe you can find it yourself. So if you look closely, in row 1, image number 7, and in row 2, image number 8 and 10, row number 8, first image, are all illegal stop signs. They are not legal stop signs. They are not in the correct colors. And therefore, the machine learning generated images that would not be found in the real world, or if they are found, these are not actual stop signs that should be respected. While this might not be the biggest issue in this situation, when we come and talk about medical images, if the images coming out are not accurate or have created new patterns, creating new diagnoses or so on, this of course becomes a much bigger issue. So here it is important to have clinicians always as guides to support what images are being produced, what data is coming in, and it means that it is very necessary for data scientists and clinicians to work very closely together to make sure that the images being produced and the data that the machine learning is being trained on is accurate. So this is a way for me to emphasize the need for collaboration and quality control when developing these AI models. As we alluded to before, based on the image generation, we are able to benefit from having more training material for students and trainees, and we're also able to create data that is more similar to local data. And this can then be used in precision health approaches by contextualizing it with the environmental and lifestyle factors, and as well as clinical applications, to be able to find insights in the images that reflect other exposures, building an association and improving treatment within that context area. On to the next stage of the flow, interpretation, and the first stage of it, detection. So I'm sure many of you are familiar with this study. The invisible gorilla strikes again, sustained unintentional blindness in expert observer. This was a study conducted with 48 radiologists where the image of a black and white gorilla was superimposed onto thoracic CT, and radiologists were asked to report their findings. And based on various opacity grades for the gorilla, and 83% of the radiologists were not able to identify the gorilla, even when their eyes hovered above it. And this has been used as a study to promote the idea of shifting the task from humans to AI, that they'd be better at identifying certain lesions. But here there is an argument, of course, to be made that radiologists aren't trained to identify gorillas. They're trained to identify and look for other nodules, so it is not in their muscle memory or recognition pattern. But also there is a reality that the inattentional blindness is something that exists not just within radiologists, but with all people. There's a similar study of people throwing a ball and the gorilla coming behind and people not noticing it. But here the idea is that detection might be better with an AI framework, but with the support to support a physician or trainee radiologist. This here is because the reality is people are not machines that will not be always operating at optimal capacity. And having them work on the detection part, which is one of the easier parts of the radiology process compared to the pattern recognition and cognitive approach, might not be the best use of time. Having physicians who are burnt out, exhausted, tired might not be great. This is especially the case in low resource settings where they might be overworked and might be looking at multiple different forms of scanning images due to the limited number of available trained radiologists to do the interpretation. And this burden and not working at the optimal capacity makes them more error prone and might allow for machines to work better. Therefore, here we can transition towards using AI to help the detection and free up radiologists for more cognitively demanding project where they are able to work at an optimal capacity rather than being burnt out. The next stage of interpretation is pattern recognition. Pattern recognition is after we've had the detection, we then look at to see if there are multiple findings and then seeing how they interact with one another and what they mean together. The example we have here is of Sybil, a deep learning model developed at Harvard's Mass General and MIT. It was used to predict the likelihood of development of lung cancer and was able to develop a positive predictive capacity of 96 to 94% of those who would develop lung cancer within the year. This was a very interesting finding and is continuing to be assessed. You can see in both images. Those on the left are what the Sybil was able to detect and predict based on that lung cancer will develop. And on the right, you can then see later on what was seen by radiologists. As you can see, it is quite difficult to identify findings on the left. And this might be difficult just because of the size of them, so they might not be seen by the human eye. And then we are talking about pattern recognition of findings that are not detectable by humans just due to their technical capacity. They're hidden behind the pixels. Then the other part is making a call based on the findings seen. Here, Sybil might have a larger database to draw on to make the assessment. But here it is also important to acknowledge that the researchers on Sybil have also said that there is a black box phenomenon here at play. So Sybil is actually predicting based on not only the inputs that they put, but also on things they are not aware of or cannot see to predict lung cancer progression or likelihood of development of lung cancer. And in this case, it is harder for us to interpret or to feel confident in using these sort of products, especially when we don't know how they're making these predictions. And this is a situation where we can use these to start identifying hypotheses and research areas to be better understood what are the predictors of lung cancer that maybe we are not aware of at the moment. So this is another example of expanding our research horizons or refining our questions. Tools such as Sybil can help with early detection, improve intervention, improve mapping of the lung cancer when we're doing invasive procedures. And all of this can be very helpful to the radiologists and other practitioners, helping them develop more accurate diagnosis and reducing the burden or invasiveness of certain conditions on the patient. The final stage of interpretation is cognition. So this is when the physician and radiologist looks at the detected images, detected findings, and the patterns and makes and synthesizes an assessment and recommendation based on. And while AI excels at pattern recognition to provide quantitative data, qualitative data is not as strong within AI, and this is a very strong role for the clinician. Also, the associations may not be very well understood. As we said from the case of Sybil, there is a black box phenomenon where we do not know what data points are being used that are helping the AI make the interpretations. This could be an area for further exploration, but it could also signify areas of bias, whether social or structural, from other findings. And here, this could, as we said, create an opportunity to generate hypotheses and research questions for further exploration and advancing our understanding on how these processes interact or how they associate with one another and increase risk or protect against certain clinical findings. It is therefore that in the cognition aspect is where the clinician has the strongest role and is most indispensable. And in a low resource setting, this is where we want the clinician to be functioning at optimal capacity to keep advancing the frontier of healthcare in that context, rather than doing the more routine work that does exhaust the brain and the body, but does not provide as much return on investment as, for example, the cognitive aspect or research. So this is an opportunity for AI to support clinicians in looking at bigger, more important questions and advancing healthcare in low resource settings. This is a figure that shows the importance of human AI interaction. It focuses on narrow task specific, and as we see at the moment, we are in the second column or area where we're seeing human and AI performance on narrow tasks, almost matching and maybe slightly improving. This goes with for beyond healthcare in many features, but we also have to acknowledge that narrow task-specific AI is what is being looked at, and that is generally not the case in healthcare, and it's not where we intend to be. We want a more holistic approach, but that means we can use AI to support that holistic approach by having areas of focus that maybe are more rare, that physicians don't look for, or that there's high inaccuracy level or improved prediction, or as we saw with Sybil, that we might not still have the ability to recognize certain features which may predict the development of something such as lung cancer, or that they are beyond detection by the human eye. And as we see in the trend here, that as AI improves, we're also expecting human capacities to improve. That shows that they are complementary and enhancing, and we need to learn to work with AI to improve what we're delivering and direct our resources to where we are better suited to perform, such as the cognitive approach, and leave more mundane or regular tasks towards AI, resulting in a task shifting towards where we have the biggest return on investment. So to reiterate, AI is a support tool to be used by practitioners. It is not something to be afraid of or to despise. It is not a replacement. It is to help us optimize. It might work in pattern recognition or detection and may act as a guardrail, suggesting we may look at something else or something we missed when certain people or certain findings may be more error prone than others. The summary is there's a trend towards precision healthcare where we are looking at multiple inputs in terms of genetics, environment, and lifestyle to help develop more holistic care within and outside of the clinic, that AI can be used to enhance the development of precision health, and that there is great potential for returns on the use of AI in precision healthcare in low resource settings to reduce wastage and improve efficiencies. The key takeaways I'd like you to take from this is it is important to engage with AI and precision health in radiology. As we said, radiology is at the frontier and is where a lot of the experimentation in both AI and precision health are occurring. And therefore, it is important to be willing to be experimental and work in this area to continue to advance it, as this is the trend where we are going and where we think we are most needed and where we think we will have the biggest benefit for our patient and our communities to advance their quality of life and create leaps and bounds of improvement in quality of life and returns in health. AI and precision health are both multidisciplinary and multisectorial collaborational areas. They require the work with data scientists, radiologists, clinical practitioners, and many more people to actually have good data that works for the patients and the communities it serves. So I would strongly recommend, if you do have a data scientist in your lab, center, university, to work with them. If they come to you to ask you questions, to be engaging, to continue to advance this area. And that, as we see with AI, it will be used to remove the burdensome or non-high return on investment tasks from physicians, which are vital in our low resource areas, to help direct care better towards the areas which are needed and reduce the burnout and strain on our limited number of physicians and our limited infrastructures. So again, stressing the benefits, we can increase access to data by generating images, by training more people. We can improve workflow. So this can be example of something like Sybil, but doing this in the center. So instead of having a radiologist technician maybe take a look or required to call a radiologist, they can flag emergencies, which then notify the radiologist to come. And this way you are reducing the time lag between the information being generated and action on the information. We can also use it to reduce errors, so to act as a balance between the radiologist reading and the machine. This way we can improve the accuracy of our reports and our findings, and of course we can use all of what we were discussing to increase and improve our delivery of care towards our patients and improve their outcomes. I would like to take this opportunity to acknowledge and thank all those who have supported me in this, from the University of Chicago, Dr. Olufemi Olopade, Professor Habibul Hassan, Assistant Professor Ali Khan, and of course Professor Goodwin Ogoble from the University of Ibadan. Thank you very much. Please find my email and my LinkedIn available. It's been a pleasure getting to speak to you, and I look forward to continuing this discussion and getting to learn from all of you. Thank you very much.